everybody, welcome back to another episode of our renal content here at Bootcamp. So today we're going to be talking about something called filtration physiology to continue on our series of the renal physiology system. We're going to break this up into a couple parts. First, we're going to talk about some of the terminology that we need, filtration fraction, and some variables affecting filtration. And then we're going to do another video. We talk about renal clearance, renal blood flow, and renal plasma flow. Following that, we'll have glucose clearance, and finally our autoregulation section. So if you guys are ready, then off we go. So first I want to talk about some terminology here, just so we're on the same page and we're not getting confused when these words are thrown around. A lot of them sound similar, so we want to think about, what is the correct meaning when we're discussing them. So think about the glomerulus, right? We have our afferent arteriole, glomerulus, efferent arteriole, we have our Bowman's capsule right here, PCT, loop of Henle, collecting duct. So when we say something is secreted, so it's going from the body into the nephron. So out here is the body and then into the nephron right here, and then it can be in the tubule and go through the whole process. If we say something is excreted, we're talking about it actually leaving the body. So something excreted is in the nephron, goes in the tubules, collecting duct, and ultimately it's excreted from the body as urine. And finally, when we talk about reabsorption, we're talking about something that's going from the tubules back into the blood. So now we have stuff that's leaving the tubule into the blood. So notice secretion is from blood to the tubules, and reabsorption is from tubules back to the blood. Excretion is leaving the body altogether. Now that we have that sorted out, let's talk about filtration fraction. So filtration fraction is our GFR, our glomerular filtration rate, divided by our renal plasma flow. So our GFR is how much stuff is actually filtered at the glomerulus. So we have blood coming in here. I've drawn this picture lots of times now. And stuff is filtered into the Bowman's capsule right here, but not everything is, right? There's more blood, there's more plasma that goes to the kidney than is actually filtered, and that's our renal plasma flow. Our renal plasma flow is how much plasma actually reaches the kidney per unit time. We'll talk more about this a little bit later on with some calculations, but just think renal plasma flow is the total amount that's going through this area in the kidney, and the GFR is how much is actually going into the tubules and actually being filtered. So notice here that GFR is estimated with creatinine clearance, and that the normal filtration fraction is only about 20%. So about 1/5 of the renal plasma flow, how much fluid is actually going to the kidney, only about 1/5 or 20% is actually filtered through the glomerulus into Bowman's capsule, ultimately into the nephron. Keep in mind that this decreases with age. The GFR, the functionality of the kidney typically decreases with age. This doesn't always mean that there's going to be an increase in creatinine level. Why is that? Why does that make sense? The reason that makes sense is because although there is a decrease in GFR, there's also a decrease in muscle mass as we age. And muscle mass and breakdown products is ultimately one of the major things that creates creatinine in the body. So yes, functionality in terms of filtration goes down, but the amount of creatinine we're making also goes down, and thus you don't necessarily see an increase in creatinine with elderly patients. However, you would see an increase in creatinine in patients with kidney disease. We'll talk more about that in the pathology section. Finally, a couple points here. GFR, I said, is estimated with creatinine, and then renal plasma flow can be estimated with something called para-aminohippuric acid, shortened for PAH. Again, we'll talk more about this in the next video. But essentially what this is saying is that 100% of this molecule, PAH, is excreted from the body. Remember what we said on the terminology slide, excreted from the body means it's actually in the urine and we get rid of it altogether. So if 100% of it is excreted from the body, that means some of it is filtered. So I'm using orange now for my PAH. Some of it is filtered, but then later on, the rest of it is actually going to be secreted into the tubules. So between how much is filtered and how much is secreted, almost 100% of it is excreted from the body, and thus it is a good measure for our total renal plasma flow, how much plasma has actually gone to the kidney itself. Next, we're going to talk about something that's super important, a very common test question for your classes and for other exams that you're going to take throughout medical school, is this idea of variables affecting filtration. So this is a great way for them to kind of test your ability to think about physiology and how changing physiologic parameters will alter the kidney's function. So first, we have afferent arterial constriction. So remember, we've talked about this a little bit now. We have the afferent arteriole coming into the glomerulus, and then the efferent arteriole, which is leaving. Then we have our Bowman's capsule, right, or PCT, loop of Henle, collecting duct. So we're talking about right here is the afferent, remember, A for arrives, and then the efferent over here. You can do E for exits. I also mentioned you could just do A before E in the alphabet to remember. So we're saying that this artery constricts. So now, instead of being, this wide, it's thinner. So what happens to overall GFR? Well, overall GFR is going to decrease. Why does that make sense? Because we're decreasing the amount of blood that can get in the area, right? If we make this tube smaller, if we compress it, we compress the capillary, less blood can get in there. So that makes sense that if we get less blood in there overall, we're going to decrease the amount that actually gets filtered and decrease the GFR. What does this do to renal plasma flow? Same thing. We can't get the blood in there, we can't get the plasma in there, so it's going to decrease the amount that is reaching the kidney overall. The interesting thing here is that it doesn't change the filtration fraction. Why is that? We said that filtration fraction equals GFR over renal plasma flow, right? If we decrease both of these proportionally, that's not going to change the ratio. It's not going to change the filtration fraction here. So there is no change in the filtration fraction. Moving on to efferent arterial constriction. So now let's say we're taking this over to this side and we're compressing the efferent arteriole. Well, now what happens to our GFR? Our GFR increases. Why is that? Remember when we talked about hydrostatic and oncotic pressures in a previous video? If we constrict the exit, if we constrict the outflow, there's going to be more of a pressure backed up into the system. So in the glomerulus, over here that I'm highlighting, the pressure in there increases because we have the same amount of blood coming in, but we're not able to have it leave the area. This causes an increase in hydrostatic pressure and thus an increase in GFR. This is going to decrease overall renal blood flow. Why? Because blood can come in, but it can't leave. So renal blood flow is how much volume is coming in per unit time, coming in and leaving the kidney. If it's a backup in terms of leaving, we're going to decrease RPF overall. And thus, this will increase filtration fraction. So now, if we look at what we have done here, we've increased GFR, we've decreased this. So overall, this is going to cause a pretty significant increase in the filtration fraction if we constrict the efferent arteriole that's leaving. Moving on to increased plasma oncotic pressure and decreased plasma oncotic pressure, they're essentially the opposite. So I like to think about them, kind of in the same way. If we increase the plasma oncotic pressure, remember we said if we have a bunch of solutes on one side, so a lot of solutes over here, only a couple solutes over here, where does the water go, right? Osmosis tells us the water goes from a low solute concentration to a high solute concentration. So it's going to go that way. If we increase the amount of solutes in the blood, so there's a lot of solutes in the blood right here, that means there's a lot of solutes right here in the glomerulus and a lot of solutes over here. What is that going to do to the filtration? That's going to decrease our filtration, our GFR. Why? Because we have those solutes pulling the fluid back into the glomerulus. Instead of the hydrostatic pressure pushing it out, we have lots of solutes pulling it back in. That's going to decrease our GFR overall. It's not going to change our renal plasma flow because, again, this doesn't affect how much blood is actually going to the kidney. What it does is it affects the content of the blood in the plasma that's going to the kidney. And thus, overall, we only have a decrease in our GFR, and thus we'll have a decrease in our filtration fraction, as you see here. The opposite is also true, right? If we decrease plasma oncotic pressure, we have less solute, we have less of a pull into the glomerulus, we're going to increase GFR. Again, we're not going to change renal plasma flow because we don't change how much is going to the kidney, we change the content of what is going to the kidney. And this, of course, is going to increase our filtration fraction because it is the opposite of having too much oncotic pressure. And the last two we'll talk about is ureteral constriction and dehydration. So first, think about where the ureter is, right? It is after the nephron. So the ureter goes through the collecting duct and then eventually, it kind of pools. And let's just say, this is our kidney right here, our ureter's here. So all this process right here is essentially occurring. It's in the microscopic part of the kidney. So everything will build up in here. And now the ureter's down here. This is where urine actually flows. It'll go into the bladder, ultimately out through the urethra. So if we have a constriction of the ureter, let's say it's normally this size, and now it has constricted and it's only this size. It's much narrower. What's going to happen back at the kidney? We have to think backwards a little bit. And this is why they love asking about these types of questions, because it causes you to really understand your physiology, to think about what's going on. We're going to have a decrease in GFR. Why is that? Think back to the kidney. If we have a constriction at the ureter, that's going to push pressure back to the arteriole. That's going to push pressure back into the glomerulus. Think about it. If we have constriction at the ureter, that's going to push pressure back into the collecting duct. In the nephron, it's going to go back through the DCT and basically work its way backwards in the loop of Henle, the PCT. And we're going to have, look at this green arrow here, essentially a bunch of pressure pushing back into the glomerulus, right? all because there's constriction downstream. It's causing a backflow pressure. So this is going to decrease GFR. Again, doesn't change how much plasma is actually going to the kidney, so no change in renal plasma flow, and it's going to decrease filtration fraction. If we just decrease GFR by itself, filtration fraction decreases overall. And the last one is dehydration. So dehydration, right? You ran a marathon, it's super hot outside, whatever it is, we're going to have a decrease in GFR. Renal plasma flow is going to decrease, and this should make sense, right? If we are dehydrated, overall we have less volume status, we have less plasma that can actually make it to the kidney, a significantly amount less so, and that's why renal plasma flow, I list here as 2 arrows here going down to show you that it's pretty significant. And then if you look at how this would affect the equation, so if we decreased GFR, but we decreased renal plasma flow more, now we actually cause an increase in filtration fraction. This is a little bit counterintuitive. They both decrease, but the ratio at which they decrease matters here. The lower the denominator decreases significantly more, and that's why the filtration, the fraction overall, increases. This can be very confusing, so I want you guys to really think about this for a second and spend that extra 10 seconds understanding it, because this makes for a tricky question that they'll get a lot of students with, but not you. And finally, the last thing we're going to talk about in this video is these molecules that are very common in the body, prostaglandins and angiotensin. Nice little memory aid that's very commonly used, widespread, is about PDA and ACE. So prostaglandins dilate the afferent arterioles. Again, you guys remember that if we dilate our afferent arteriole, so if we're looking over here, right, and we make this wider, so I'm dilating it, what's going to happen? Well, let's look up here. We dilate our afferent arteriole, it's going to be the opposite of this. So now we've made it wider, we're going to increase GFR, we're going to increase renal plasma flow, and still probably not have any change to the actual filtration fraction. And the last one they like you guys to know about is angiotensin and how it constricts the efferent arteriole. This becomes super important when we talk about the RAS system, the renin-angiotensin-aldosterone system, a little bit later on. Think about it, right? Just what we learned today. So it constricts the efferent. So what happens? Efferent, we're talking about this one over here. If this arteriole now looks like this, it's constricted. Think about what's going to happen. It's exactly what we just talked about up here. If the efferent arteriole is constricted, we're going to increase GFR. Why? Because we've caused an increased hydrostatic pressure in the glomerulus itself. By narrowing the space that the plasma can actually leave through the kidney, it's going to increase hydrostatic pressure, cause more of it to be filtered. This overall is going to decrease renal plasma flow. Why again? Because there's an outlet obstruction. It's easy for the blood to get in here, but it's hard for it to get in and out on this side because it's constricted. And finally, this is going to increase filtration fraction overall. So that's all I have for this one. We'll pick it up on the next one and continue our discussion about filtration physiology.